Hello, Dr. Rajesh.
Hi Priya. How are you?
Fine, thank you.
Okay, nice.
Arul is also not able to join. Some
Okay.
death in the family. She said she will not be.
Oh. Okay. Yeah, Vishnu is joining. Good. Yeah. Anyway, we'll have to discuss a few things. One is Dr. Sanjaya wanted to have a 1 minute video, for the ASCII.
Yeah. I'll. I'll do something. I have good experience on iMac now.
Okay. Yeah. I think you can
I
take the
can.
lead, and I
Yeah.
can.
Definitely. I'll have some ideas, so I'll just do it and show it to you. Hi,
Okay.
how are you?
Hi, ma'am. How are you, ma'am? I'm fine, thank you.
Yeah. Hi Vishnu. Good evening.
So,
How are you, sir?
Yeah. Fine.
ASCII this time is hybrid mode, so I think many of us should be able to attend. We should attend that.
Yes. Yeah. Vishnu, just to you want to check share screen and
Yes, sir. I'd like
working?
I'll just try that once. Yeah.
Hi, Pudivan.
Hi, ma'am. Good evening, ma'am.
Hi Pudi, good evening.
Hi, sir. Good evening, sir. Hi, Vishnu.
Hi, Budhi. How are you?
Fine.
So, how is the physics series going now? How many more lectures?
Um, there are two more on cardiac on MR, cardiac MR. Then two more on CT before the conference, annual conference.
I'll just rejoin. I have to quit and reopen it.
Okay.
Yeah, I'll just quit and log.
Yeah, hope others also will join. I think we need to discuss few the official matters also for the conference. I think Hemant will join.
So, anything new done recently, Pudivan?
Nothing significant, ma'am. That's the routine work. So,
You have a lot of transplants happening at your center, right?
cardiac transplants, ma'am. No, ma'am. Not much cardiac transplants here.
Okay.
Yes, yeah, it is working. Yeah, slideshow mode, play.
Yeah.
Yes, yeah, good.
Who is Dr. Arvind Shashi Kumar?
Probably some son. These are all the problems, with the online
Yes.
classes, the children.
Yeah. Agreed.
So, yeah. And Vishnu, do you have that other article which is not freely available? No, only the this thing abstract is available.
Yes, sir. I got a copy of that.
Okay, fine. Yeah.
I mean, most of it is in the abstract itself. They have the article had few images which I'll be showing in the presentation.
Okay, fine. Yeah, that is good.
One quick question. Any way to make the point visible always in Keynote?
In Keynote, I'm not sure. I don't use it that often.
It was not working, so I had to make this
Okay.
Keynote. So as soon as I change the slide, it is going to the arrow is disappearing.
Okay. I hardly use Keynote. I use PowerPoint in Mac only.
Okay, this is my first time using Keynote, so
Okay. I also tried it once for a presentation, but then I don't know. I think since I'm used to PowerPoint, I found it.
yes.
I think
I
I
found
can
it a little
see
bit cumbersome.
a lot of other people are joining. I can see, I think there's something wrong with the link. Syed, Karar Ahmed, Arvind Shashi Kumar.
I think these two are my residents, I think.
Oh, Oh, okay.
I think
okay.
Vishnu has. Okay, Vishnu's residence. Okay.
The link in the flyer was not working.
Yeah, I will send it again.
Yeah.
Good evening, Vishnu.
Sir, good evening, sir.
How are things?
Fine, fine, sir.
Hello, Johan. Good evening.
Good evening. Good evening.
Good evening.
Yeah, what we'll do is we'll start. I think Amit is not there, so maybe we'll start with the presentation. Then maybe at the end we'll have a small discussion on the conference matters. So I welcome you all for this Journal Club presentation. So today Dr. Vishnu going to present two interesting articles on left bundle branch block and its the role of cardiac MRI in differentiating just LVBV causing versus secondary to cardiomyopathy. Anyway, there are two articles are there. He is going to discuss. It's a very important topic. Those who are regularly doing cardiac MR, and I feel Dr. Johan will give a lot of inputs on this. It's very important for electrophysiology point of view. Yes, Dr. Vishnu, please you can start.
Thank you, sir. So today we'll be discussing about important topic of left bundle branch block in a setting of a dilated heart, especially dilated left ventricle. As you all know, this is a common combination that we come across when you are imaging for a dilated cardiomyopathy. We find a paradoxical motion of the interventricular septum, and on exploring or reviewing the records of the patient, most of them tend to have a left bundle branch block. So in this combination of dilated left ventricle and a presence of paradoxical motion of the interventricular septum, it becomes important for us to try to differentiate between a primary cardiomyopathy causing dilated left ventricle, which ultimately can result in left bundle branch block, or a left bundle branch block which can precede a dilated left ventricle. So it is, what is left bundle branch block by definition? It is a the ECG criteria is very clear on this. If the QRS complex is prolonged more than 120 milliseconds, we tend to call it as a left bundle branch block morphology. So because of this left bundle branch block, there is delayed activation of the left ventricle. What happens is, because the left bundle branch is blocked or the conduction is delayed through that, the activation of the ventricle happens through the right side of the interventricular septum. So the septum activates first, followed by the apex, and then at the end, the basal free wall will be activated. So because of this, there will be a significant delay of the activation and relaxation of the ventricle. So there will be a global discoordination of the contraction relaxation mechanism, which is usually denoted with the term interventricular dysynchrony and intraventricular dysynchrony. So both of these conditions happen because of the delayed conduction through the left bundle branch. So morphologically, what do we see in these patients? We see a characteristic early systolic or pre-ejectional shift of the septum towards the left side, followed by a paradoxical movement immediately to the right side, that is towards the right ventricle. That uses the classical appearance of septal bounce or a paradoxical septal motion. So this over a period of time can cause severe LV remodeling effects in form of LV dilatation and increase the LV mass. So this eventually can cause decreased diastolic filling, leading to both systolic and diastolic dysfunction of the left ventricle. So the relationship between the LV dilatation and dysfunction is very complex, and it is still poorly understood. That is why there is still a dilemma of something analogous to chicken and egg dilemma. So we are not sure. We don't have mechanisms to establish whether the left bundle branch block has caused DCM, or DCM has eventually led to development of left bundle branch block. So why is this important? Because there are guidelines for treating patients with dilated cardiomyopathy, and if the left bundle branch block has preceded the dilated cardiomyopathy, and the recommendation is to use the therapy for 3 months before giving trying out other modalities of treatment. So that the crucial time of 3 months will be wasted if we do not identify the left bundle branch block as preceding the dilated cardiomyopathy. So this is one factor. Other factor being we can prognosticate which patients might respond better when we know which has occurred first, the bundle branch block or the dilatation of the ventricle. So in that effect, I'll be discussing these two articles, which might help us to throw some light about understanding the pathophysiology of this condition. So the first article is in this article by Hu Wang, MD, and others from Shanghai University in China. They retrospectively studied two different subset of patients with patient records which are available, which documented the presence of bundle branch block on ECG, followed by and others which didn't have any bundle branch block on ECG, but they presented eventually after initial diagnosis of DCM into two separate groups. So what they found was, in these two different sets of groups who had chronological events of one following the other, the group of the patients who had bundle branch block documented before the dilatation of the heart, they had a characteristic preservance, or they have characteristically preserved function of the lateral wall. That is, the lateral wall thickening as well as the contraction was preserved when compared to the other group of patients who had dilated hearts followed by documented development of new left bundle branch block. So their conclusion based on this was, if you see a patient on a cardiac MRI, compare the thickness of the septum versus the basal lateral wall. If the thickness of the lateral wall is higher than the septum, or if the contraction of the lateral wall is preserved, whereas the septum is thin and akinetic and not thickening on systole, then these set of patients might probably had left bundle branch block to start with, and which eventually led to dilatation of the ventricles. And the converse is true for the other set of patients. I will show you a few illustrations from the article which will help us understand this in a better way. So this is the first example of that of a this is a index case from set of individuals who had a bundle branch block first, and then dilated, and then the LV dilatation was documented. So in these patients, if you compare the diastole and systole, you see that the diastolic frame, all the walls are uniformly thickened, uniform in thickness, whereas in systolic phase, you can see that the lateral wall is becoming more thick compared to the septum. So same thing is highlighted in this color illustration superimposed on the cardiac MRI image. You can see the relative thickness is more during systole in the lateral wall. So this means that the contraction of the lateral wall is preserved in this case. Though the septum is thinned out, the lateral wall contraction is preserved. So this was the morphology of the LV which was noticed in the patients who had first left bundle branch block followed by the LV dilatation. Conversely, in a subset of patients who had dilatation of the heart first followed by the left bundle branch block, they could see that if you see the diastolic wall thickness and the systolic wall thickness, you can see that the wall thickness of the lateral wall is not increased in systole, meaning that the left basal lateral wall is not contracting as well compared to the other set of patients. So this was the characteristic which they found when the patient had dilated heart followed by the development of left bundle branch block. So that is how you can throw some insight of whether the bundle branch block preceded the dilatation or the dilatation preceded the bundle branch block. So the sequence of events that are hypothesized are, so once a left bundle branch block develops, there is early activation of the septum followed by delayed activation of the lateral wall. This over a period of time, because of the dysynchrony in the LV contraction, what happens is the interventricular septum becomes thinned out, whereas the lateral wall thickness is preserved. Subsequently, over a period of many months or years, there is a ongoing remodeling happening in the ventricle, which eventually leads to overall decreased thickness of the entire LV. But even in those patients, you can see that the lateral wall thickness is more than the septum, and as well as the contractility is still preserved in the lateral wall. So based on these findings, you can differentiate which might have occurred before the block or the dilatation. That is about this article. That's what they tried to demonstrate in this article. Well, there are few limitations in this study, namely that this was all retrospective studies based on the patient records available. They divided the patients into different groups, and then this was the observation which they came out with. So to make this into a clinical decision pathway, or make it to bring it into the clinical guidelines, we need to do a proper randomized control study, which is of prospective design to document the changes in a better way. So now we can, by using cardiac MR, say which occurred first, the bundle branch block or the dilatation. Once you are there, once you have identified or once you have determined based on clinical details and the imaging criteria that the bundle branch block has occurred first, which led to the LV dilatation, then comes the question of identifying subset of patients who will respond to CRT therapy. CRT is cardiac resynchronization therapy, or subset of patients which might not benefit from the CRT. The school of thought behind this is, though there is a though this is a well-known phenomena that left bundle branch block with dilated cardiomyopathy, still this entity is not classified into any of the established cardiomyopathy classes. So there is still a lot of unclear things in the pathophysiology of this process. So in that context, there is one more article which was recently published in which tried to look at primarily left bundle, primarily in the sense idiopathic left bundle branch defect, idiopathic left bundle branch block. That is, in these subset of patients, there is no other known cause which might have led to the bundle branch block or the dilated cardiomyopathy. So these are the subset of patients in which this study was done, which identified two different subset of patients, even in the case of idiopathic left bundle branch block. So they coined the term, or they used the term called LBBB induced cardiomyopathy. So even in these subset of patients, even these patients, they found two subsets, as I just said. So what they did was, in a patient with left bundle branch block, when the ventricle contracts, what happens is, as the lateral wall finally contracts, the septum is actually moving away from the lateral wall. This leads to mechanical decoupling, and which eventually leads to effectively decreased ejection fraction or decreased stroke volume. So what they did in this study was, they corrected that septal flash volume. I mean, we use the term called septal flash volume. That is the quantity of the volume of the blood which would have been pumped by the proper positioning of the septum during systole. That is what septal flash volume. I'll show it in the illustration so that you'll understand in a better way. So what they did was, they did this calculation of septal volume, and when the septal volume was subtracted from the end systolic volumes, you actually get a corrected ejection fraction. That is, you are correcting the decreased ejection volume or decreased stroke volume contributed by the dyskinetic septum. So that will give us the actual ejection fraction. So they found that in certain individuals, even after the septal volume was corrected, the ejection fraction was less and the ventricular volumes were higher. So that indicates that not only there is a mechanical dissociation which is causing decreased ejection fraction, leading to increased volumes, there might also be underlying contractile dysfunction or myocardial pathology, underlying pathology, which explains why even after the correction of the septal flash volume, the ejection fractions are still lower in those subset of patients. So the basic takeaway point from this is, if there is a patient of left bundle branch block and all other pathologies are ruled out, and if it is considered a primarily idiopathic LBBB or LBBB induced cardiomyopathy, we can, by use of cardiac MRI, derive corrected ejection fraction, corrected LV volumes. And even after doing that, if there is a decreased function, we can say that this subset of patients might not respond as well as expected in a case of isolated bundle branch block patients. So I'll show the. So they also evaluated the T1 mapping using parametric sequences, and they also found that so these are the gist of the findings which they found. When the corrected LV ejection fractions were measured compared to the controls, patients with purely LBBB with asynchrony and LBBB with superimposed hypocontractility, the corrected ejection fraction was less in this group, those with underlying cardiomyopathy. And if they looked at, when we look at the T1 values, those with left bundle branch block had elevated T1 values compared to the controls. But when they looked at the patients with the superimposed hypocontractility, the T1 values were much more higher. Similarly, end-diastolic volumes are also higher in this subgroup, and septal native T1 times were also very high in those patients with superimposed hypocontractility. So based on cardiac MR, we can differentiate these two subset of patients in patients with LBBB associated or idiopathic left bundle branch block cardiomyopathy patients. So how they did was, so this is the illustration showing how they calculate the septal flash volume. So this is the end systolic time frame. So in diastole, all the walls of the ventricle are in relaxed phase and there is no paradoxical movement happening. So only in the end systolic frame, you can see that the septum is moving away from the cavity, leading to decreased stroke volume. So this blue outline is the actual cavity of the LV, whereas this green area is a assumed or assumed or interpolated contour of the left ventricle in systole, assuming that there is uniform contraction of the entire LV wall. So if there had not been a left bundle branch block, the septum would have been here. So what they did was they assumed a circle based on the contours from the lateral wall, and then they finished the circle so that they could assume a position of normalcy when left bundle branch block was removed from equation. So this red area corresponds to that flash volume. That is, this is the flash volume, which can be corrected by doing a cardiac resynchronization therapy. So this volume was removed or subtracted from the end systolic volume. So this by that they derived the corrected ejection fraction and corrected LV volumes. So what they noticed was certain subset of individuals had normal corrected ejection fraction and normal corrected LV volumes after the septal flash volume was removed. In those same subset of patients, they could also show that the global T1 values as well as septal T1 values were elevated, but not by great margin from the normal range. Whereas there was other subset of patients where they found the corrected EF was decreased and corrected LV volumes are also very high in these patients. They showed significantly elevated T1 values all across the myocardium as well as in the septum. And when they interrogated the LG sequences, they found that there was in mid-myocardial fibrosis happening in the second subset of patients, which is much more than what was seen in the purely LBBB subgroup. So this says that apart from the mechanical dysynchrony happening, there is also a subset of patients who has underlying intrinsic muscle abnormality that is shown by these corrected functional analysis as well as elevated T1 values. So that is this is also one of the methodology which can be used to identify this second subset of patients. The importance being that these patients might not respond as well as those with the first group when a cardiac resynchronization therapy is advocated or performed in these patients.
Yeah, thank you, Vishnu. Very nice, very simple and nice presentation. And have you checked your own cases? Any of the things, whether these things are applicable? Things like lateral wall thickness or contractilities, we can easily see it. Maybe.
I read these articles maybe a month ago. So I had some 3 patients which came with similar clinical picture, dilated cardiomyopathy with bundle branch block. So 2 of them had preserved thickness of the lateral wall and really good thickening compared to the septum. But the third patient had decreased, the wall thickness was not preserved as well as the contraction of the lateral was also not very good in that patient. So one of them went for CRT and I'm yet to get the follow-up on that patient. But the other 2 patients, they are still on medical management. They are not decided to go for the device yet. So I spoke to a cardiologist also regarding whether this information will be useful for them. This is relatively new in the literature. It has not, because it is not in any of the guidelines to use the these criteria to identify subset of patients who will respond or who will not respond. But what they typically follow is whenever there is a LBBB morphology on ECG and there is a dilated cardiomyopathy, the reason for which they send for cardiac MR or imaging is to look for any scar in the myocardium. Their present understanding and hypothesis that if there is a scar and they do implant a CRT, those patients are less likely to respond to the CRT. That is the current standard of practice. So the two articles which we discussed today, they might be helpful in the patients when the LBBB was discovered for the first time, because all these patients are actually roaming around getting different types of therapy, basically guideline directed medical therapy. Whenever in a peripheral center, whenever the heart is found to be dilated on echo, the first thing they do is they do a coronary angiogram. If it is normal, they keep on heart failure therapy. I mean, they do not do targeted therapies yet in the peripheral centers. So
So even in the main centers, the important thing is assessing the responders versus non-responders are very critical, because the CRT therapy is very costly. So compared to that, MRI is very cheaper. So it's ideal to do all cases before CRT. Then you will get a much better understanding. That is the one. And the second thing is regarding the second article. Suppose if you want to calculate the that flash volume, so whether just putting a circle, how they how we can do we need any special software, or how they used? Are there any details?
They did not use any specific function, sir. They assumed they took a circle ROA and they started and they put in such a way that it covers most of the lateral wall. This is something analogous to what we do to calculate the loss of glenoid labral area in recurrent dislocation of shoulder. We assume a circular shape of the heart, and then we adjust the contours in the software so that you get a corrected volume. So otherwise they did not specify using any separate tool. I think we can do it in existing softwares. First do the normal calculation, then using a circle ROA in the software, draw a circle ROA, and then adjust the systolic endocardial contour conforming to that circle, so that you can get a approximation of the corrected volume.
Okay.
So, I mean, I did it on one patient and I found the EF, initially it was 32. After doing it, it went to 45. And volumes also decreased by 30.
Okay.
So I have to see in few more cases and see if and how we can use it for the guideline.
Okay. Yes, Dr. Johan, your inputs.
One other thing what we have started reporting is about this septal lateral delay. On the circumferential strain images, we can actually see the amount of time it takes the impulse to reach from the septum to lateral wall. And if it is more than 150 or 200 milliseconds, then there are good chances that he will be a responder to CRT. Dr. Johan, any?
Yeah, two or three things. LBBB evaluation, we've been routinely doing with echo for the last maybe eight, very standard thing. It's and we look at the delay both in terms of we look at the QRS delay, we look at the QRS delay to the opening of the aortic valve also, and the QRS delay to the opening of the pulmonary valve. So this represents the interventricular delay. And the intraventricular delay, we look at the widening of the QRS. Also the distal to QRS and the lateral to QRS. So you get to delay or dysynchrony, and you get to lateral. So this is a very standard practice. Reason why possibly all CRT operators do a ECG you have to have something more than a to 160 generally what is taken before you can even think of a CRT in an LBB situation. So MRI has fairly late to this part because standardization is a problem, and the EG, the EC plays a lot of havoc inside the maggot, and coordinating the QRS with the opening of the aortic and pulmonary valve is not well studied, although it may be done in some research places. So LBBB evaluation as such is very, very robust and very, very well done on the echo, number one. Number two, MRI has added a better quantification, as we said, to do protocol to get a better EF and also a better volumetry. It is important, as very well said in the article, to differentiate between a primary LBBB and a secondary LBBB, because we know that many myocardial diseases develop LBBB as a late onset, as a follow-up to the disease itself. Whereas a primary LBBB generally starts with the ECG abnormality, then they have a perfusion abnormality. We see this routinely on nuclear scans, especially. And finally, they have a LV dysfunction, a volume, and a thinning abnormality. So that's the sequence generally which is there. ECG, perfusion, and volumetry, and the fraction being.
Dr. Johan, your volume is breaking. Your voice is breaking.
Can you hear me?
Yeah. In between, little some break there. Yeah. Okay.
Yeah. So you can have three kinds of patients with LBBB. The first patient will be a patient with LBBB, ECG, normal perfusion on either MRI or nuclear scan, and a normal ejection fraction and volumetry. The second LBBB patient will have an LBBB on ECG, abnormal perfusion either on the nuclear scan or on the MRI, and normal volumetry. The third patient with LBBB will have an LBBB on ECG, abnormal perfusion, abnormal volumetry, and abnormal ejection fraction. So these are the three general kinds of patients with LBBB we see. The third patient with the completely abnormal ECG, perfusion, and volumetry is generally the end result for a lot of myocardial diseases. LBBB is the end result for a number of myocardial diseases. And these are the patients who will have a poorer EF, poorer volumetry. They will have thinning. They will have a lot of thinning, especially in the lateral wall. And also, they will have a peculiar scar pattern, especially if the scar pattern involves the lateral wall. Then, generally, these patients are not good candidates for CRT, because the CRT catheter that we put in is in the posterolateral wall. It goes into the posterolateral vein, and that supplies the posterolateral wall. So once you have scar tissue, the ability for the pacemaker to sense and to drive the wall becomes limited. So one of the important things that we do on MRI is to look for either edema or scarring in the lateral wall. And if extensive or transmural, this patient almost becomes a complete it is a complete thing for not doing the CRT. However, the last is with backup. May still achieve some results, but not complete. And then the third issue of whether the LBBB is driving the cardiomyopathy or the cardiomyopathy is driving the LBBB, as Vishnu has already brought out very well. The important things to note is that history is very important and past investigations are important. Then describe. If a patient starts off with a bad LV with a normal ECG and later develops an LBB, the cardiomyopathy which is driving the LBBB, However, the patient for the last 10 years has an LBBB and progressively decreased LV function, then it's the LBBB driving it, and that's where a CRT makes a difference. The thickness, as is already mentioned, also makes a difference. Generally, a primary LBB will have a normal thickness. However, patients with a myocardial pathology causing LBB, the thickness will be different. So just a few comments. It takes a little bit of practice, lot of BBs. In fact, one of our very common referrals will be because we have people who do CRTs who refer to us regularly for some of these issues. Thank you.
Yeah, thank you, Johan, for nicely summing up the important findings. Any comments from other people? Dr. Priya, Sanjaya, Aparna. Any personal experience? Generally, we do the cardiac MRI mainly to look for the scar, and if there is a lateral wall extensive scar, generally they won't do the CRT. So that part we know. Only thing, the other things are new to me. Any other personal experience? Anyone?
That was a great article, Vishnu, Dr. Vishnu. Congratulations. So this is something new, really. We also are not doing lot of care. We are not doing any work on this. True, we are only looking for scar, like Dr. Kannan said. But yes, it would be great to follow up these patients, not only T1 but also see ECG mapping and strain analysis to pick up early patients who still don't have LV dysfunction. So that would be great. I'm looking at some research topics. So this has given me a thought regarding some research which we can do. Good. That's a great topic.
And Vishnu, if we have the final copy of that article which is not available, if you can share it with us, we can also discuss with our cardiologist.
Yes.
Yeah, again, congratulations, Vishnu. I think that's a great topic. And Joanne, thanks for explaining things very clearly to us as well. I think this is very interesting. Priya, the other Priya, I just had a question for you. How do you measure the delays? Are you doing it? What are you using to measure the delays?
Circumferential strain with feature tracking using the short axis cine images. It plots the time curve. So basically, you know that when the impulses reach the septal wall, you can actually check it from all the 16, 17 segments. And that is how we can plot when the maximum impulses reach from the septum and when it has reached the lateral wall. I can share it. I will share the screen shots in our group then.
Anyway, this delay they can see it in the ECG itself, no?
Echo
mixed with the ECG. Yeah.
Yes. Echo, they see the QRS time, and I think the echo 2D echo they can calculate the delay.
Yeah, this is very interesting. If you could share some articles.
I will share it in our group.
Yeah, please do.
Dr. Priya, I think this option is there in Neosoft.
Yes.
I think I remember seeing it in one of the demonstrations at Satyasai Hospital.
Yes.
They have this separate tab showing this strain-based
16 segments. That is why, yeah. So I think
it gives the value actually. How much dysynchrony is there? It gives a value. Yeah.
There is a dysynchrony index. Machine can calculate. The software is capable to do that. All these are still research sequence, nothing FDA approved, but I think we need to work on it more so that we can get some conclusion for future health.
Okay, so any other comments before moving to the conference topics? If there are no more comments, so few things we want to anyway discuss. as we all know that October 14, 15, 16 we are planning the annual conference Goa. Hope all of you might have registered for this. If not, please register as early as possible. So the plan was to have two parallel sessions. One going to be anyway will be starting on Friday afternoon. So the program will start at 2 p.m. on Friday, that is October 14. Then 15 full day, and 16 Sunday morning I mean till afternoon 12 o'clock. So the plan is to have both fun and the scientific program. So it's the main idea of Dr. Hemant. He didn't join today. So the and it's going to be parallelly. We are going to have a pediatric cardiac workshop the same time. So starting with the Friday afternoon, Saturday full day, and the Sunday morning session. So and anyway, we are inviting the ASCII speakers as usual, as well as speakers from SCMR. So already some of the speakers were confirmed, as well as from MGH Massachusetts General Hospital also. Now we are getting speakers. So I need the anyways help to form some teams. One is we also planning to have a paper under the poster presentation as usual, and those who have experience last year, please come forward and you can take up that. So basically we need to form guidelines for the oral papers and the poster presentation, as well as the coordinating with the for the getting all the papers, sorting out and all those things. Anyway, those who are done last time, at least one person can start, as well as maybe one or two new people can join them. Last time who was it involved?
Myself,
Vishnu and
Sudivan,
okay.
Dr. Aparna.
Okay. So is it possible to take up this? So we need to basically the same guidelines we have to follow this, so that we are going to announce it. If we have that email ID and all, then we can use the same email ID. I think we have one as ISCA videos at gmail.com. No,
Yeah.
is that still it's active?
I have to check with Trupti.
Yeah, it's active.
Rajesh, can I just say one thing?
Yeah, yes.
Can we please not have people sending on the email, because it's headache to again generate one Excel sheet.
Yes.
We'll make it on Google Forms. It's very easy. It'll just generate its own Excel sheet.
Yes.
No problem of missing at all. Last time we missed one, a lot of confusion, because so many emails will be there. Although it is only same thing, somebody will inquire something. In between, we'll miss things.
Actually, from different emails also, that led to a little more confusion last time.
Yeah, we had a lot of confusion, and I was thinking that I should help highlight that we should just do it on a Google form. I'll volunteer to make the Google form and give. I have many ready-made things like that. I can just make and give you.
Okay, so Aparna and Vishnu, can you do this?
Yes.
Yeah. Okay. So now basically now we can make the Google form and as well as the guidelines. Now we can anyway will be circulating very soon after announcing it, so that once we have all those things, then maybe in another 2-3 weeks time maximum, if we can get it, we can circulate it.
The guidelines that I sent to you, is that all right? Do you, or I can put it up in this group so that if anybody has any other ideas, they can change.
Yes, please. Yeah, we can put it in the group, then we will modify it then before making it final. Okay. Yes, Dr. Richa.
Stop the recording because this gets put on the website. Journal club discussion.
Okay, yeah, but I don't know how. Then we have to everyone rejoin. Now I think we can tell them to edit this part.
Okay.
Then other thing is on the last day we are planning to have interesting case discussion almost exclusively by our executive committee people. So the plan is now to present one interesting case by an executive member. Whatever case they have come up, either it may be a typical presentation of a common disease, or some common presentation of a bit rare disease, something interesting to everyone. So you can start thinking about it and prepare the case. And again we need a volunteer to coordinate for this. Basically we have to get all the cases. Suppose in order to avoid overlap, if 2-3 people are presenting the same type of cases, we can, if they have options, then we can modify it. So the idea is first of all we should know how many of you are going to present. This is going to be more than 2-hour session. So the plan is to have say 8-minute presentation and maybe 7-minute of discussion. So 15 minutes per case. So total we can take about 8 to 10 cases, interesting cases. Hope that will be very useful for us, because rather than having just lectures, every one of us have seen lot of interesting cases in your day-to-day life. Even though some of the cases are worth publishing it, but still you will be reluctant to do those things. But at least it will be good others at least come to know that such a because we might have done lot of follow up and the investigations to make that diagnosis. So yeah, we can start the getting those cases, and the at least if we can give the type of case or the diagnosis earlier, so that we can try to avoid overlap.
I can volunteer to do that. I can.
Yes. Yeah. So.
Yes.
And of course Priya, so we need to do that 1-minute video presentation. Yes, Dr. Sanjaya, anything you want to add that for the ASCII people?
So ASCII has requested each country to give a 1-minute video presentation, and we have accepted that on behalf of IACI and India. So the guidelines are shared with the group and with Priya. So Priya, over to you in terms of how you want to do that. I know that you, Yash, Megha, Rita, that's a fantastic job last time.
Yes.
So you can do a fantastic job this time as well.
Yeah, definitely. I will do something. I have some few past pictures of our past conferences, and just all the activities of ICI with some Indian twist. So we can portray that how from India we are doing that, and I will think of something creative and we'll do that.
I think 15th June is the last date to submit it. So at least by first week of June, if we have it, then we can give our own all the inputs. Then we can, if anything needed modifications, we can do that. It's just 1 minute, and putting everything together is a little tough job. And finally, Sanjaya, you will send it to them now if he.
Yes. I would need to upload it, or so if you can just send it to me.
Definitely.
If we can review it once, maybe as Rajesh is saying, before June 1st.
Yes.
Or even June 7th, and then maybe
definitely.
finalize it by June 7th.
No, I'll do that. Sure, I'll do something before this month end, so you have enough time to look for editing, etc.
Yes. Okay. Thank you. So then.
All the other people, I mean, this time ASCII is online, so whoever wants to attend, probably this will be a good time that in a hybrid mode you can attend the conference. It is going to be in end of June.
Yes. Yeah. So still the registration is open. So those who want to, then so maximum can participate this time will be easier. And the last one is I think Dr. Alpa might have contacted some of you for the pediatric cardiac workshop. I think Dr. Aparna, Megha, Priya Jagia is there. So we are, she has included a few people, and since we don't know whether other people have a good experience in pediatric cardiac imaging, please let us know so that we can include you for the pediatric cardiac workshop also. So already the program is the outline we got the outline, and Dr. Alpa Paradhi from Mumbai, she is the main organizing person for this. Anyway, she is not attending this meeting. So those of you who want to contribute either cases or you want to present, please let us know. Either you can contact me or Dr. Alpa.
Rajesh, can I make one quick comment?
Yes.
So regarding ASCII, I would really request all of you to also join in the monthly ASCII seminars. They are actually very good. Some of them are brilliant, some of them are moderately good, but they're all above average, above thing. They
definitely.
Are by different locations. Narayana and Vimal's team did it last time. Richa was one of the speakers. So I think the more we participate in that, the more our presence will be felt in ASCII. That's one request. Second request is that if you if you can actually join ASCII as a member, that will also be very helpful, because I think we just don't have enough of Indians who are part of the membership. And I think being a member of ASCII has its own advantages, including, of course, just bolstering the Indian presence in ASCII as well. Joanne has been a big proponent of ASCII for us. Firstly, I want to thank him for really for spearheading it in the last several years.
Yes, yeah. So yeah, we should be able to maximum participate in these activities. In a long run, it's going to be a lot of help for us. Yeah. Anyway, they are very much eager to join our programs and all. So it's very, very useful. Yes. So that's it. Any other comments or anything else needs to be discussed?
Sir, I have one query.
Yes, Nilay.
As we will be taking two programs simultaneously, are we going live again on two platforms, or will it be on the same? Because I think we have a hybrid sort of thing.
No, right now I think Hemant is not there. The plan is anyway it is the live program, on-site program, and the pediatric workshop going to be exclusive on-site and the hands-on program, and even the other parallel program also it's likely to be on-site. Only the later we may give option of the offline meeting, and the speakers, most of the speakers are willing to come, and they are going to come on site to present. Only very few speakers they will be giving lectures by recorded talk. Otherwise the many speakers already has agreed to come, and it's going to be on site. The offline part still we are not yet decided. So whether
no for the audience.
Yeah, for the audience, even for the audience. Anyway, for the pediatric part, there is no recording anything offsite. It is going to be fully online, on site only. Yes, for the pediatric cardiac. The adult part still not decided about the offline mode at all. I mean online mode at all. Sorry. So it's going to be fully in person program. So we'll request everyone to anyway book your tickets and visit. And anyway, we are planning lot of other entertainment activities also. The idea is the first day the program will be over by 5 p.m. and now we will be having evening beach dinner sort of things, as well as even the second day the program we are planning to finish by 2 p.m. itself. so that we have some time for to move around and all. And of course, third day will be over by 12 p.m. So it's going to be a lot of fun. So okay, so if there are no more comments, shall we wind up?
Thank you, Rajesh.
Okay, thank you. Good night, everyone.
Bye.
Thank you.
Good night, sir.
Thank you, Vishnu.
Thank
Good
you.
night, everyone.
Thank you,
Thank
everyone.
you.
Good night.